My name is Caldera. I'm an interventional cardiologist at Baylor Scott & White, Round Rock in Texas.
Hi, I'm Paul Mahoney. I'm the Chief Interventional Cardiology for East Carolina University in Greenville, North Carolina.
Okay, well, thank you for being here, Paul.
Thank you for having me.
Very proud to have you as a clinician who I train in TAVRs, but we look up into the people who had more experience, have been in high referral centers. And the concept of TAVR in native anatomy evolved since 2009 to the current present. And then it was found that it was a good alternative for patients who had a failing bioprosthesis. And now we know that somewhere between 2015 and 2020, most of the failed bioprosthetic valves are being treated with a TAV-in-SAV. And you have been there from the very beginning. And I would like to ask you, from your perspective, what are your goals of therapy? And what are the complications that you fear the most? And how do you try to prevent them or address them?
Well, great question. Thank you for inviting me to the conversation. Like TAVR itself, TAV-in-SAV evolved out of our desire to treat desperately ill patients. We had these failed surgical valves. We didn't have an indication. They weren't good surgical candidates. So we're looking for something to offer them. And so with the absence of any real other therapy, we started putting these TAVR valves into surgical valves. And when we started doing it, there was no other option. And so we weren't worried about coronary access. We weren't worried about patient prosthesis mismatch. We were just trying to get these sick patients out of the hospital. And it worked pretty well. And based on mostly registry data, and we were able to bring this forward as a therapy. What's really changed now is it's trying to make this the right therapy for the right patient. Yeah. The things I mentioned, how do we make sure that we've got a low enough risk procedure, because a surgical redo valve for a lot of patients is still a good option. So when is this the preferred option? When is this the only option? And if it's the only option, what do we need to do it safely?
So the field has really moved. By 2024, of 3 failing surgical valves, 2 are being treated with TAV in surgical.
Yeah.
So tell us a little bit about the platform that is there. What do you keep in mind when you are deciding which valve to implant, and what are the best strategies to accomplish the best hemodynamics?
That's a great question. Not all surgical valves are the same. Some we have the ability to modify the ring itself. The leaflets are sometimes on the inner part of the valve, sometimes on the outer part of the valve, sometimes they're bovine, sometimes they're porcine. So having a knowledge base of the surgical valves is important. What we really want to do when we're looking at this is we want to make sure that we take a prosthesis, a TAVR valve, that's going to give the patient the best hemodynamics, the safest implant, and minimize the amount of sort of other things that we need to do to expand, to modify leaflets, to try to correct a patient prosthesis mismatch. And a lot of times, our surgical colleagues have evolved with us, but 10, 12 years ago, there may have been some undersizing of the surgical valves that we're just now learning about. So how do we mitigate that by putting another valve inside of that? And how do we best address that? And so on a case-by-case basis, we'll sort of look at all those factors, also keeping in mind that for some patients, surgical redo and maybe even an enlargement might be the best option. So it's very individualized, patient-specific answer.
Talk about coronary occlusion, because obviously the risk of coronary occlusion approaches 5% when you do a TAV in surgical. And now we have prediction models using CT. So walk us through your decision-making based on the CT. What are the key numbers in terms of BTC or other variables? And then also, afterwards, do you keep these patients in anticoagulation? What do you do in terms of antithrombotic and antiplatelet therapy?
Yeah, really important topic and good question. We're sort of in the infancy of really understanding this. As you pointed out, in TAV-in-SAV, you can see as high as a 4 to 5% incidence of coronary occlusion. And there's reasons for that. When the surgeon implants the valve, very often they'll put it in a supraannular position. So coronary heights relative to the surgical valve can be quite low. They can be 2 to 3 to 4 millimeters. And they try to put as big a valve in as they can. So all of a sudden, when you put a catheter-based valve in, you take the leaflets of the surgical valve, you push them against both the coronary itself and against the sinotubular junction, and can create sinus sequestration. If you get acute coronary occlusion during a TAVR, that carries with it about a 40 to 50% mortality rate. So it's a dread complication. So we really started to look at it. So one of the things we look at is the distance of the valve leaflets to the coronary. All right. In general, if those are an internally wrapped valve, if they're 4 millimeters or less, we consider that at risk. Similarly for sinus sequestration, and what that means is that the leaflets of the original valve are pressed outward by the TAV valve, and they extend up, and they basically exclude the sinus, the coronary sinus from the coronary circulation, and this is obviously a bad thing. So if we see a VTC, a VT-STJ, a valve to STJ ratio of 2 millimeters or less, that's an indication that we need to do something. And usually we want to modify those leaflets, splay them in some manner to allow for coronary sinus pressurization. And in that case, we know at least the coronaries are getting pressurized and they're filling. Where the exact thresholds are is still to be determined. If we're predicting that this patient is at a high risk of this complication, and we know this complication comes with a high mortality, is this now a high-risk TAVR? And looking back at what other options, is this maybe somebody that we should reconsider surgery in rather than doing a bunch of leaflet modification? I think we're still trying to answer this question.
Are these numbers different if the leaflets are externally mounted?
They are. And that's, so the leaflet thickness on an average surgical valve is about 2 millimeters, so an externally wrapped valve, which was thought to give better hemodynamics, but that means they're outside of the post of the surgical valve. So when you expand your TAVR prosthesis, they're a little bit more likely to occlude. So a VTC you add basically 1 millimeter or 2 to whatever your measured VTC is, and 3 millimeters becomes a real problem. So that's a fairly high risk. Now, parenthetically, those sometimes are the hardest to treat because of the outer wrap makes leaflet modification a little bit more challenging, but it's important to recognize that as a risk factor. Since you have to decide what your threshold is. If you predict that if in a usual case it's 1% risk of coronary obstruction, if you predict do you modify the leaflet at 10%, at 20%, at 50% risk of obstruction? Generally speaking, if the threshold is crossed where I think I need coronary protection, I will modify the leaflet. Because our ability to precisely put the valve exactly where we want is not perfect. It's a beating heart situation, oftentimes rapid ventricular pacing. Sometimes the valve is just a little bit hard to control when you're talking about millimeter differences. So,
with all this manipulation in the ascending aorta, and if you're doing leaflet modification, and we know intrinsically the TAV-in-SAV has an increased risk of a stroke, the data about these protection devices, it doesn't seem to be very encouraging in the native anatomy. What are your thoughts? What are you doing in your practice? Are you using cerebral protection devices in this case?
Yeah, really, really important topic and good question. The short answer is no. And one of the reasons for that is we've yet to demonstrate any patient population that seems to benefit from the only commercially available dialysis with Sentinel. In the Basilica registry, which was about 252 patients, it's just non-randomized, but about half the patients got Sentinel, half didn't. We didn't see any difference in stroke rates. There's a cost associated with the Sentinel device. There's a theoretical risk of manipulating a catheter in the aorta. And it's very hard to pick which patients are kind of Sentinel worthy versus which aren't. So I think it's kind of an all or none. At this point, we're not using anything, but I really look forward to a device that will reduce stroke that has proven efficacy, because I think this is a high-risk patient population.
So now that you have modified the anatomy and you have the leaflets of the bioprosthetic valve open and you have the concept of the neosinus and the flow dynamics, at the beginning we were anticoagulating these patients. Yeah. Some advocate for single antiplatelet therapy and only anticoagulate if the gradients are higher. What are you doing in your practice?
So, yeah, as you know, TAV-in-SAV and especially TAV-in-TAV are associated with higher rates of leaflet thrombosis. So when the patient will tolerate it, generally speaking, we'll try to do a course of anticoagulation, usually with Eliquis, usually for at least 6 months. Is there data behind that? There's some anecdotal data, there's higher rates, but whether that's a more efficacious plan than DAPT or single platelet, I think remains to be seen. But you have to be very vigilant for signs of this. There's a lot of the flow mechanics between the stent valves are worrisome. So we hedge our bets a little bit and we use Eliquis for 6 months in patients who are appropriate candidates.
So now with all this information, what is the future of redo surgery in a failing bioprosthetic valve? As I mentioned before, almost 1 out of 3 is undergoing surgery. Many of them are going TAV-in-SAV. So what do you think is going to happen moving forward? Will always be a room for surgical, or is TAV in surgical?
Well, as I tell my surgeons kind of jokingly, you'll always have endocarditis, all right? So there's always going to be a role for surgical approaches. One of the challenges, frankly, in this day of transcatheter valves is how do we maintain a core group of surgeons who are skilled at doing complex aortic surgery, that can do these procedures. That's a separate podcast, but it's something to think about. I think the future is going to, I think leaflet modification is going to continue to be a really important topic. In an ideal world, why would we ever leave the leaflets behind? So we need technology that, one, can remove as much leaflet as possible, as safely as possible, as efficacious as possible, and cost effectively, and if such a device does exist, that would be tremendous. And we also need to make it so that most operators are comfortable using it. I think that would be kind of the holy grail of valve-in-valve, and it would allow us to treat a lot more patients safely with a catheter-based approach. There's a lot of interest in this. There's a lot of movement towards this. I don't think we're there yet. So I think for right now, the best approach is a careful review of the CT on a patient-by-patient basis, assess the risk, the risk to the patient of, is this a high-risk TAVR or is this a standard just pop a valve in and get out of there? In that case, we all agree TAV-in-SAV is the way to go. But in these high-risk cases, you have to balance what you need to do to the patient versus their surgical risk and decide what platform is going to give you the best result, and then go on a case-by-case basis for that manner.
Thank you, Paul. I think this has been a great review. Any final remarks you want to do about this topic?
No, it's a pretty exciting time to be looking at this. I think this is going to be an important ongoing issue for our field. And I just want to thank you. You asked great questions and keep me on my toes. I appreciate it.
Thank you, Paul. Appreciate it.
Thank you.